a pleasure for me to present Dr. Tosoian. He's going to be talking about diagnostic biomarkers for prostate cancer currently and in the future. Currently, Jeff, Dr. Tosoian, is an assistant professor at Vanderbilt. Before that, he was at Johns Hopkins for his residency, his MPH. There he worked with myself, Ted Schaefer, and others. Val Carter was really a superstar, extremely well published, extremely productive. Went on to the University of Michigan, where he did his SUO fellowship. Again, published at the level of a lot of actually full professors around the country. He's been heavily involved in the early detection of prostate cancer, has leadership roles in the EDRN. He works with the also in the VA and with the SPORE programs where he's at. He's had a long commitment to looking at biomarkers both in the urine and blood for diagnosis of clinically significant prostate cancer. And he also has kind of helped usher MIPS, which is a test that many of you may be familiar with, onto the market and into clinical use, particularly the newer version of MIPS. So Jeff, I mean, really overjoyed to have you, and looking forward to your talk.
Thank you. Thanks so much, Ashley, and thanks for having me, everyone. Are we hearing me okay? Seems like it. So yeah, as Ashley mentioned, I'm Jeff Tosoian. Joined faculty at Vanderbilt around 2 years ago now. We've been building some infrastructure here to be able to study biomarkers of really all the GU cancers. And so today we'll talk about biomarkers of prostate cancer at the diagnostic phase. My disclosure would be the SelectMDx lab. I'm a co-founder of that. That is the lab that commercializes the NPS test. And so just looking at the outline, we'll start with the state of care and get into the basics of biomarkers and how we assess them. I'm going to be particularly brief in those sections for this audience, but figure I would give a brief background. And then we'll look at the biomarkers currently proposed in the NCCN guidelines and talk about, in particular, one emerging biomarker, which is the MPS2 assay that we have been working on since started my fellowship in 2018 and have continued to work on that here with largely with Arul Chinayan, who's my mentor there at the University of Michigan. As we all know, the first step in early detection and diagnosis of prostate cancer remains PSA. As we also all know, PSA is a marker of prostatic epithelium, not cancer. And clinically, that results in several potential adverse outcomes when PSA is used as an isolated diagnostic test for screening. These are just some of the data from the ERSPC, which shows that 3/4 of biopsies triggered by PSA will be negative for cancer. Of those that are positive, only half will be clinically significant. And so certainly there is improvement to be made there. And so PSA as an isolated test is not great. And for that reason, beginning in 2019, our guidelines have offered MRI and consideration of biomarkers prior to biopsy to better define risk of clinically significant higher grade disease. And so what are biomarkers? As mentioned, I will be particularly brief here, but a few definitions exist, and one that I've found to be my favorite is from a review paper. And really, it's just the objective nature of biomarkers to me is a defining quality and what differentiates a biomarker from imaging, which as of now remains subjectively assessed. And so when we talk about how we assess biomarkers, there's of course analytic validity, more looking at the lab setting and does the assay actually measure what it's intended to measure. On the flip side, there is at the other end of the spectrum, there's clinical utility. So does the use of a given assay change the plan of care and subsequent outcomes for patients? And then, of course, there's clinical validity, which is measured through the performance measures that we're all used to hearing about, specifically sensitivity, specificity, and negative and positive predictive value. And so, since we're going to be looking at the literature, a lot of data, wanted to just review the fact that sensitivity and specificity are, of course, by definition, relative to a given threshold for a test that's used to define it as positive or negative. And so we often say, what is the sensitivity of that test? And the reality is it can be anywhere from 0 to 100, depending on where that threshold is set. And so implicitly, when we say that, we're talking about the sensitivity at a given threshold. Sensitivity and specificity are more optimal for when we do want to make cross-study comparisons, given that they are inherent measures of a test and do not depend on pretest risk or commonly the prevalence in the cohort. By contrast, positive and negative predictive value are dependent on the risk. And for clinical data, that's reflected in the cohort's prevalence of the outcome. And so which numbers matter? This was something that, as I had the opportunity to lead some of the validation studies and subsequently development and validation of the MPS tests, spent a lot of time thinking about reading the literature that does exist and talking to peers. And so, one area where I draw a distinction is, from the patient perspective. And so when we're talking about prostate cancer here, we have the patient saying, I want a test with a high negative predictive value so that if it's negative, Ted doesn't have to go after him with the ultrasound probe. And as the clinician, we're of course saying, I agree, it's critical for each patient. We use a test with 98% NPV to avoid a biopsy. There's only a 2% chance that performing the biopsy would have been helpful. Thinking more broadly from the clinician's perspective, here we have a clinician who's been clearly working very hard, caring for many patients. And so when he thinks about his overall practice or in the overall population, and I think this is one thing that's often overlooked. I know in our space, a lot of tests focus on NPV, having a strong rule out, but really, sensitivity, when we think about the overall population, is what tells us essentially how many diagnoses we could miss. Or for prostate cancer, we always say it in terms of missed or delayed diagnosis. And so if I'm thinking about applying a test to my entire practice, or even on a higher level, to the overall population, we really don't want to have a test that doesn't have high sensitivity, or else we're going to be missing those diagnoses. And so here, Dr. Ross says, if I use a test with 98% sensitivity in all of my patients to rule out a biopsy, it means I'll still detect 98% of clinically significant disease if we had biopsied everyone. And so in this diagnostic space for prostate cancer, really, and most would agree that, we need to emphasize sensitivity after PSA, and then, as the better tests have come along, we're seeing that specificity climb to where hopefully we can start avoiding, upwards of 50% of those biopsies that would have been negative or low-grade disease. And so I just included a brief summary of data on the 6 markers currently included in our guidelines. And to name those are Prostate Health Index, 4K score, isoPSA as the blood-based markers, and SelectMDx, the ExoDx IntelliScore, and the My Prostate Score, or MPS. And those are the urine-based tests. And so these are proposed for use in, of course, these patients with moderately elevated PSA greater than 3, or an abnormal DRE, to better risk stratify the likelihood of clinically significant disease, or in more practical terms, really, I think most of us use these as rule out tests, to where if a patient tests negative, we can feel pretty confident that we don't need to proceed with additional testing. And so just for this review of the data, we only included validation data. We only included publications where the patients were, our appropriate clinical population, those referred for an elevated PSA or abnormal DRE. Included studies that reported on clinically significant disease, and only included studies that reported sensitivity and specificity, or at least the data to where we were able to calculate those. And so anytime I'm looking at data in this space, one thing that always is important to note is this previous biopsy status. I think it's maybe been a little bit overlooked for many years, though now it's much more acknowledged in the literature that patients who have had a negative biopsy in the past are actually at decreased risk of clinically significant disease when clinically significant disease is found and they go on to surgery, found to have decreased likelihood of adverse pathology. And so it really is a more favorable cohort. And then context for all the studies will, of course, be talking about whether it was an overall quote unquote referral population, or whether the cohorts were limited to a specific PSA range, for example. And so we'll start with the 4K score, which is, of course, one of the blood-based assays. PSA, or human kallikrein 3, is one of the 15 genes in the family of kallikrein-related proteases that contribute here. And so the 4K score includes 4 of these in a proprietary calculation, and results in a % risk of clinically significant disease. And so 4K score does include age, prior negative biopsy status, plus or minus DRE. They've since validated it to where that is optional, and as mentioned, gives a percent risk or percent likelihood of grade group 2 and above disease. And so the studies that really, help us to try to get a sense of where these biomarkers are landing in terms of their performance. These 4 characterize that well, and as you see, sensitivity ranging from 90 to 97%, specificity in the 30s to 40%. And of course, inherent with those sensitivities are the likelihood of missing a clinically significant cancer here ranging from 3 to 10%. And so really just plan to go quickly through these data to get a sense of where the field is right now in terms of the accuracy and performance of available biomarkers. And so the Prostate Health Index, very familiar to many people in the room, also provides a continuous score that is reflective of the likelihood of clinically significant disease. Here is the formula of PHI, and similarly, a body of literature here that shows sensitivities in the mid 90s, with specificity here ranging from 12 to 30%, and of course the clinical outcomes that come along with such a testing approach in terms of the biopsies avoided. Specificity is in this setting, specificity will always be equal to the proportion of unnecessary biopsies avoided, as we see that reported often. So those that would have been negative or had grade group 1 cancer. And of course, as the inverse of the sensitivity, the proportion of clinically significant cancers missed. We'll move along to the first of the urine tests, SelectMDx, which incorporates 2 urine-based cancer-associated markers with PSA and clinical factors. As shown here, these are post-DRE urinary specimens, and really their large initial biopsy data show similar performance. Their threshold here was set to allow a somewhat lower sensitivity in this PSA less than 10 cohort, but a higher specificity.
We're good.
Notable that the formula does include prostate volume, which and so when prostate volume is not included in the formula, yes. So we'll move along to the ExoDx and telescore, or EPI, which again includes 2 cancer-specific markers with the housekeeping gene SPDEF, and actually does not require post-DRE urine. Any urine specimen is usable for the ExoDx test. Similarly, as kind of has become the standard, the test provides a continuous score, providing the likelihood of clinically significant disease. And ExoDx, has a somewhat smaller literature base than the blood-based test. Really, all of the urine-based tests do, though I always felt that these studies were well done in the transparency of who was included, what the cohort characteristics were, and provided usable data. And so, here we just see that in the initial biopsy setting, getting sensitivity of 92 to 93%, specificity around 30%, with around a quarter of biopsies avoided. This group was the first to publish specifically in the repeat biopsy setting, looking at 229 patients with, as you'll note, the prevalence of significant disease is lower in the repeat biopsy populations. And so using that same threshold provided a sensitivity of 82%, specificity of 27%. And so really that, one thing I took from that was, that I think these cohorts should be assessed probably independently with a separate cutoff in the repeat biopsy setting, which is something I've applied in the studies we've done since. So looking ahead to the My Prostate score, or MPS, that includes, again, 2 of the cancer-associated markers, PCA3 and the T2 ERG gene fusion with PSA, did not include clinical factors. And these are indeed post-DRE specimens. And so these were the validation studies that we've put together in the last couple of years, looking at the 2 cohorts separately. So in our initial biopsy patients, seeing a very high sensitivity with the ability to rule out about 1/3 of unnecessary biopsies. When we applied a more strict definition and really limited the cohort to PSA of 3 to 10, the numbers were quite similar. And that's all to say that the larger cohort included some patients with PSAs slightly above 10. It was kind of the quote unquote overall referral cohort. And so restricting that to PSA of 3 to 10 really did not compromise performance there. We more recently looked at a repeat biopsy cohort across the EDRN, which again, as you note, has a lower prevalence of clinically significant disease. And we actually published on a couple of threshold values, but I've included the one here that provided 100% sensitivity while ruling out about a quarter of those unnecessary biopsies. And finally, the isoPSA test, which has several publications in the last year or so. Really the one here met all of the criteria from the review, as I noted. And so that was a mixed cohort of both initial and repeat biopsies. And they reported a sensitivity of 90%, specificity of 45%. And so, when I try to summarize the existing data, certainly all of these markers, all of these cancer-specific biomarker tests do provide diagnostic information beyond PSA and PSA-based models like the ECPT risk calculator. Really, the extent and quality of the data vary widely. And one thing that really has changed over the last 10 years is our understanding of low-grade prostate cancer as a truly indolent entity. And so while the markers applied in these assays are cancer specific, which provided an advantage relative to the non-specific PSA, none as of yet had included any markers that are specifically overexpressed by the higher grade cancers or have an association with grade of disease. And so a little foreshadowing there. Also to say, when I think through biomarkers, we had our first generation test, which was PSA and was specific for the prostate, but not for cancer. I think the field, did improve with several of the markers that are specific for cancer, but again, with how how clinical practice has changed and this the focus really being on higher grade cancers, I think kind of the ceiling of performance of those markers may well be limited. And so, kind of started thinking ahead to a third generation where we could include markers that were specific for high grade disease. And so we'll talk a little bit about that, and the work started when I was a fellow at Michigan, and that we're continuing now. And so this is all to say, as mentioned, the available markers have an association with any grade of prostate cancer, but we thought that identifying and incorporating markers specific for high grade disease, while also using current technology to incorporate additional markers. You may have noticed the current assays all include up to 4 various markers. And so we'll talk a little more about the work we did to try to bring multiple markers into to a practical format, practical platform for testing. And so here just, and this is from a TCF grant, just saying, hypothesis being that the addition of novel markers that are biologically associated with high-grade cancer to a testing panel would significantly improve our discriminative accuracy for clinically significant disease. And so, as it built upon the initial My Prostate Score test with the 2 cancer-specific markers, went ahead and called this My Prostate Score 2.0. And so we'll talk briefly about kind of the discovery phase, which was looking at RNA-seq data. So that was tissue-based RNA-seq data for novel markers associated with, yes, cancer again, but uniquely high-grade cancer. And so we carried that out in the publicly available data through TCGA and GTEx, and supplemented that with 119 specimens from University of Michigan. There you see the grade group distribution, and identified a priori specific nomination criteria to identify cancer specific and your high grade specific markers, with an emphasis on, because we knew that we would want to translate this tissue based discovery to a less invasive urine based assay. A lot of the criteria were focused on identifying markers that are highly expressed in general, and then of course with notable differential expression in the higher grade cancers relative to low grade or benign tissue. And so really this is just an illustration here of those data. And we'll go through kind of the whole process there. And so the analysis looked at almost 60,000 genetic targets overall. There were 72 that met the predefined nomination criteria. 22 met those high grade specific nomination criteria and showed increased expression in higher grade relative to lower grade cancer. And 50 met the kind of more traditional cancer-associated nomination criteria. Take a minute to talk briefly about the platform for this. Certainly you can pursue sequencing and whatever else of urine or more commonly tissue to risk assess. The thought here being that we wanted to identify a platform that could be expandable and would be more widely adoptable. And so PCR, sure most folks are familiar with, and then using this newer open array technology, actually able to multiplex several markers rather efficiently and practically, to where including several markers in an assay was feasible. Here, just kind of showing the translation from our tissue-based findings to a small pilot cohort that we had run the urine on, looking at SHLAP1, one of the high-grade markers, and PCA3, one of the cancer-specific markers. And notably, expression was successfully measured. And so we'll talk a little bit more about that here, in that of the 72 markers that were nominated, there were some that when we went to design the probes for the urine-based non-invasive detection, ultimately was not possible. And so between that and removing those that were highly cross-correlated, we ended up with 44 of the nominated genes. We supplemented that with 10 potential control genes like KLK3 and some of the well-published cancer-specific targets that for whatever reason were not identified in our RNA-seq analyses. And so that left us with a 54 gene or 54 target candidate panel. And briefly, here are all the genes that were included in that. It included 27 cancer specific, 17 high grade specific, and then 10 that were selected for either published association with cancer or known suitability as a gene for normalization, as a reference gene. And so we applied that to a development cohort, and that was an institutional cohort at the University of Michigan. Men referred for biopsy with a PSA of 3 to 10. In order to avoid kind of the ascertainment bias that would come with having a mixed cohort, we did limit it to patients that had not undergone a pre-biopsy MRI. Working with Bruce Trock at Hopkins and others, found that with our samples available, a case control approach would be very suitable. And so you're just showing that with random selection of among the controls, yielding about a 1.5 to 1 control to case ratio, we had sufficient power for detection of up to 20 markers. And so here's just to say the development cohort, as you would expect from the inclusion criteria, was consistent with our patients that we see with this in terms of median PSA. Of course, this cohort, as many are, was limited in diversity, and so we are actively pursuing development of, potentially an alternative algorithm, but at least assessment of that in a predominantly African American cohort. And so the 54 markers were, expression was measured in terms of the cycle threshold, and ultimately was normalized to KLK3. Based on the fact that prostate volume is rather consistently informative in these clinical assays, but that it's not always available. In other words, patients who have not had either a previous biopsy or an MRI will not have a measure of prostate volume. We decided to develop two tests in parallel, so that the information provided by volume could be used when it exists, but that the model is not dependent on it, as some others are. And so I'll kind of breeze through this, but used elastic net regression across multiple resamplings of the development set to identify markers that contributed significantly. Based on the design of the open array plate, we knew that running a total of 18 markers in a given run was kind of a practical number. And so the thought was, any that are significantly contributing to accuracy, up to 17, so then we could run also the reference gene along with them, would be included. And so the importance of each marker to prediction, as well as the frequency with each marker was, showed up across the 40 resamplings in an optimal model, was used to rank the markers for their importance, their contribution. And so that's shown here, and ultimately had an 18 marker panel that includes 9 cancer specific, 4 high grade cancer specific, 4 that were selected for literature reflecting an association with either cancer or high grade cancer, and then the KLK3 reference gene would make up the final panel. And so looking initially in the development cohort, as you would expect, PSA provided an area under the curve of about 54%. Incorporating the clinical variables did improve that to 61% by way of the PCPT risk calculator. The previously developed NPS test, the two marker plus PSA test, improved upon those with an AUC of 72%. And looking at the NPS2 and NPS2 plus markers, with cross-validation, but of course this is still the development cohort, improved the AUC to 80 and 82% respectively. And so, as we all know, when possible, external validation is a higher quality of evidence. And so through the EDRN, the Early Detection Research Network, is a branch of the NCI. Through our kind of national network, we looked at an EDRN cohort of patients recruited from 2009 to 2011 for elevated PSA or abnormal DRE. This was across 11 academic sites. Here's just to show from consent to final enrollment. The final cohort did include 743 patients. Again, important to show that the cohort is consistent with the population for whom biomarkers are offered, and that's men with an elevated PSA or abnormal DRE, but generally not excessively high PSAs. And one unique thing about this cohort is that, of course, PSA and the PCPT can be calculated, and we're able to calculate MPS and MPS2. This cohort actually also had PCA3, which is one of the components of MPS, but also prostate health index data available. And so, as many know, right, one large limitation in this space is a lack of head-to-head data of biomarkers. And so in this analysis, which this was actually kind of just breaking news, so I think actually, Ashley, you don't even know about that yet, but yeah, we were able to find that we had those data, and so we will be able to include kind of that head-to-head comparison of the new MPS2 with both the prior MPS and with prostate health index, which is one of the blood-based markers currently offered for consideration. And so they have not yet given me the AUC for, and I guess it's worth noting that the external validation, was truly external, not only in the sense of an external cohort, but the analyses were all defined a priori and were run by Yimie Zhang and her team at Fred Hutch, and they were the only two investigators with access to the data at all. And so still awaiting the PCA3 and PHI AUCs, though I think, to me, this is kind of the most important data because it tells us, if there's improvement at that, high sensitivity threshold that makes sense to use clinically to rule out higher grade disease. And so as you see here, looking at the overall cohort first, at the 95% sensitivity, the novel test, the MIP2 and MIP2 plus, did improve substantially the specificity relative to the prior generation markers here. Those two range from 23 to 26%, with MPS 2 and 2 plus at 37 to 41%. Of course, along with that comes a very high negative predictive value. And as mentioned, the unnecessary biopsies avoided as reflected by the specificity. When we look specifically in the biopsy naive subgroup, the improvement persists. Again, at the high sensitivity threshold, specificity of 27% with MPS, 30% with PHI, and 35 to 42% across the MPS2 models. And then here in the repeat biopsy cohort, of course, a smaller cohort, 250 subjects, and as we saw from the ExoDx study and our prior MPS study, this is actually larger than any of the previous published repeat biopsy cohorts. And so you see here the new assay really does improve significantly upon the priors. And part of that may be limited number cohort, though I remember Phi includes all PSA related substrates. And so, we already know that in this repeat biopsy setting, that PSA is a less helpful marker. So, there is some biologic plausibility to the idea that incorporating more non-PSA related markers would lead to a truly substantial improvement like we saw here. And so, in summary, adding these novel non-invasive markers, including several for high-grade cancer, to the MPS model, and thus building MPS2, led to some notable improvements in specificity at the 95% sensitivity threshold. And so, I think there's some reason to believe here from these data that this could offer a big improvement in the biomarker space. And just as general conclusions, we know that the currently available markers do improve upon PSA, though the data are vary widely in extent and quality of various markers. And so, the data we're looking at here, I think, shows a lot of promise that newer biomarkers, potentially specific for high-grade disease, can really offer some improvement beyond the status quo. And so, many people to acknowledge, as noted here, largely, as I mentioned, Arul Chanayan, my mentor and now collaborator, everyone that had participated with the EDRN. That's been a very, very valuable resource for developing and validating the new and the older tests. Some of our funding here. And with that, I'd love to take any questions. I really appreciate you. Thank you all so much for your time.
Hey, thanks so much, Jeff. That was great. A couple questions since the test that's clinically available that we can order now is the MIPS 2+, or is it the MIPS 2?
It's both of them. And so, they've, and I say they meaning the lab and kind of the sales folks, as I, stay more on the academic and research side of it, but they've set it up to where, you can order the test with whatever clinical data you have available. And so if volume is available, you would essentially, they'll run the 2+ test. The publication will, of course, show, where those differences are, and that is, of course, reflected in the score reports. And so you can actually even submit it without any of the clinical data. Again, in data I didn't show here, but you may have seen, we actually found that running the biomarkers only without the clinical data, had a rather small decrease in performance. And so again, with the score report reflecting the test that is run, you can send it with any extent of clinical data or not.
And then a couple other questions. So what PSAs, I assume you're using the test to figure out who should go towards an MRI, or maybe in some cases who should go towards a biopsy, which might be a more expensive test or more invasive test. Again, remind us, what PSAs did it validate in? Is it 2 to 20? Is it like, where's the range?
Yeah, so, and that's something we're pointing out again in the manuscript. When we set up the development, it was a strict, PSA 3 to 10 or PSA less than 3 with an abnormal DRE. The validation cohort included PSAs as low as 2, and again, this is all kind of clearly specified in the paper, as low as 2, some in the 2 to 3 range that were referred for a biopsy because of essentially PSA velocity. And then we did keep the patients that had PSA above 10 that were presenting for repeat biopsy, just because, as you know, right, clinically, PSA in that repeat biopsy setting is often much less reliable. And so it didn't really make clinical sense to exclude patients with a PSA of 11 or 12 in that repeat biopsy setting.
And then, finally, and a lot of other people ask questions too, but, our institution has a MIPS, has PHI, and a lot of our practice is to use PHI as our gateway test to kind of spare people biopsies because it's cheap and it actually is within our system and it comes back quickly. I don't know if you have access to things like PHI at Vanderbilt, but if you did, where do you see the places of MIPS? Should we be using MIPS instead because it can save 50% from biopsy instead of like 25% from biopsy or MRI? Should we be using it as a secondary test where, we've had a negative biopsy and we're still scratching our heads about the need for a repeat MRI? Where do you see in an institution like ours that has, ready access to PHI? Where do you see it?
Yeah, no, it's a great question, right? And kind of when I would often look at the prior, everything short of the newer test, I don't know what your thoughts are. My kind of belief is that, all of those tests probably have pretty similar, kind of biologic signal, ability to inform us. And so, I think the reality is that for most people, most providers, it is a question of what's easy, what's convenient. I not mostly just because, maybe because I led the analyses, but like for MPS, I, do prefer the sensitivities of at least 95%. I think when we're talking about sensitivity closer to 90%, and especially with some of the tests that are validated at thresholds with an NPV closer to 90%. I don't know. I personally, in talking to patients, I think 10% risk of significant disease is more than at least a proportion of patients want to take on that level of risk. And so I do kind of favor those with a clearly validated threshold that can highly accurately and with great reliability rule out the need for MRI or biopsy. Like you said, I do, all other things being equal, I think we have, these data are as good as any that, showing that the new MPS2 does appear, at least in this cohort, to provide a notable boost in specificity, where we're hopefully able to rule out upwards of 50% of unnecessary biopsies while still maintaining that very high sensitivity. So I think I've always kind of envisioned an approach where we're able to write a biomarker we can get right there in clinic quickly, easily. It's objectively measured, and rule out hopefully upwards of half of the unnecessary biopsies. And then from there, I think it makes sense to talk about MRI, to what, as the data for MRI really are strongest in that role, right? In its ability to improve detection of clinically significant disease, whereas the MRI data for ruling out the presence are less impressive. At AUA, the Music statewide collaborative showed NPV of just 77% of MRI when, across academic and community practice. And so maybe there's some personal preference there, but I love the idea of running a biomarker that tells me I can rule out having to do anything else with a really high level of sensitivity and NPV, and then for those that we can't rule out, moving toward MRI and biopsy.
One more question, if I could. I'm wondering how you talk to patients. We've gone to a full exposure to patients to some of the nomograms we've made. You may have seen one of our recent publications on MRI and PHI, and I think we'd love to do some similar collaborations with MIPS. And it's interesting, I'll show a patient the actual risk count, and I'll tell them what I would do. And, if it's a 5% risk of at least in grade group 2, I tell them I would probably just keep monitoring. But a lot of them say a 1% risk, and they're going to do something. So how have you messaged this? And I wonder if you put on your company hat, how do you decide how to talk to patients about, decision tools, to talk to patients about these things? You just tell them what to do, or how do you do it?
Yeah, no, it's a great question, and I tend to, so the patients that are going to want to have a biopsy regardless, and really, if a patient, right, if a 5% risk of significant disease or less, is not not enough for them to feel comfortable deferring biopsy, then, of course, I wouldn't recommend a test. So I think I'm actually doing the opposite of putting a company hat on right now. But as you know, right, we want to make the, use the test where it's going to be useful. There actually is some literature in this space talking about what are reasonable thresholds. A lot of the decision curve analysis literature with Andrew Vickers. And one that's always stood out to me was just saying that a risk less than 5%, given practice and the fact that these aren't men that are generally lost to follow-up, but rather it's usually diagnosed later rather than miss altogether. And with that 5%, meaning that you would actually be doing 20 biopsies to detect one significant cancer, I think 5% or less is sufficient, for me. And so I do kind of tend to speak in that way with patients. We talk about upwards of 20% being it's probably worthwhile to go to a biopsy. And so really, right, that 5 to 20, 25% range is where I think these tests can be very helpful. The one setting we didn't talk about today, but right, in men who have had an MRI, really that PIRADS-3 group, we published on the first MIPS test and showed that using that in the PIRADS-3 cohort, really improved upon even PSA density to be able to determine who should and should not go on to biopsy. But ultimately, right, it's kind of one of those just conversations with the patient is 8% more than, is that more than you can sleep well with at night? Though I do think, as maybe you do too, we're all, I think, growing a little more tolerant of taking on some additional risk, with the understanding that we're continuing to follow, these patients. And so it may not be biopsy right now, but check again in a year and reconsider at that time. Thank you all
Thanks so much for being
so
here.
much.